Hi, it's Dr. Centeno. Thanks so much for being here today. Today we're going to talk about an interesting topic. This is the You've Got the Power show. So we're going to talk about the differences between PRP and bone marrow concentrate and what that means. What is PRP? What is bone marrow concentrate? And we're going to focus on how those treatments are used to help ligament problems heal. So, are we talking about, for instance, something that where one is better than the other? Is PRP better than bone marrow concentrate? Do they work differently? Do they work the same? When would you recommend one over the other as a doctor that uses both? All that good stuff. Just like usual, I will go ahead and answer your questions, whether it's about this topic or any topic. And the goal of this show is, again, just to get patients really educated about what the choices are, what the choices mean for them personally, risks, benefits, what works, what doesn't work, what the lab tests mean, what the diagnosis means, what this MRI result means. How does that affect me? All of that stuff, because educated patients are so much better at navigating the healthcare system. Because let's face it, our healthcare system is confusing, it's difficult, it's not very patient friendly, and patients that don't get educated, in my direct experience, tend to make bad choices. So we're going to try to prevent that today. So let's go ahead. I'm going to share my screen here. So I'll get started. We've got a watcher out there to make sure this is really working like it's supposed to. So it looks like my screen sharing started right there. And I'm going to start with this topic. And again, the topic is, today we'll be talking about the difference between PRP and bone marrow concentrate for ligament healing. So again, PRP versus bone marrow concentrate, or what we call BMC. So, and this topic was really started by a craniocervical instability patient I have who contacted me relaying that he had spoken with a prolotherapy doctor or traded some emails, not us, someplace else. And that prolotherapy doctor had told him with a lot of assuredness, or a lot of certainty in his voice or in his email, that PRP injections were definitely far superior to bone marrow concentrate injections to help ligaments heal. And he reached out to me and said, well, that's kind of the opposite of what I've heard. Can you review that for me? So this is actually a blog, and we'll put that blog post, which is just a couple days ago, in the show notes so that you can go ahead and look that up and get deeper into that blog. So there's more to this than just today's video. So first, is that statement true? Second, do we have any research that shows that one is better than the other for ligament healing? And then what's my direct clinical experience, since I've used both of these now for almost 20 years? So first, what is PRP, or platelet-rich plasma? So again, the P stands for platelet, the R for rich, the P for plasma. So the doctor draws blood, and then a machine, usually a simple bedside machine, concentrates the platelets in the plasma. Now, the simple bedside machines can only do so much because they're simple. So because of that, we don't do it in a simple bedside machine. We have a $1 million lab facility in our practice where that gets done. It gives us much more flexibility. We can do much more, obviously, than a simple little machine and kit. Now, PRP is believed to work by platelets secreting growth factors and exosome signals that help to orchestrate the healing response. So for instance, platelets will release these growth factors on day 1, these other growth factors on day 2, other growth factors on day 5, etc. And how I like to explain it to patients is that PRP is kind of like espresso shots for local repair cells. So let's say we had a construction site and the workers didn't seem to be working all that hard. So you go out, you buy 100 espresso shots, and you say, here, guys, drink these espresso shots. And obviously, you know, for the rest of the day while they're popping their espresso shots, a lot of work is getting done. That's what PRP does. It acts as a stimulant for those cells. Now, what is BMC, or bone marrow concentrate? Bone marrow concentrate is created by the doctor drawing bone marrow aspirate through a specialized needle called a trocar, and that's at the back of the pelvis usually. And the stem cell containing fraction of the bone marrow is isolated and concentrated, and that becomes bone marrow concentrate. Now, this is believed to work through the mesenchymal stem cell content of the bone marrow. And these cells also excrete growth factors, exosome signals. They can also, at the end of the day, turn into the bricks and mortar. So mesenchymal stem cells kind of act like general contractors, right? They can bring in other cells to do various types of work. And in the weird way the body works, when they're all done telling all the other workers what to do, they can also turn into the bricks and mortar, or the drywall, or whatever, or the studs, for example. So is there clinical research, and I looked this up pretty extensively a couple days ago because I was interested to see, well, maybe there was some clinical research published that I didn't know about. Now I look at that a lot, so that seemed unlikely, but I was happy to go and check it again. So there is no clinical research that shows that PRP is better than bone marrow to treat ligament injury, because they've never been compared head to head in that kind of clinical research trial. Now, the closest study that you could get to would be our tenocyte paper. Tenocytes are very similar to the fibroblasts that occur in ligaments. And what we ended up finding was a pretty interesting dose-response relationship in platelets for stimulating tenocytes to repair. So what that meant was that if the dose was on this side and the healing, if you will, in the lab was on that side, that the higher the dose in older patients, the better the healing. And that creates a problem in PRP because most PRP machines can only do about that much on the concentration side when you get to that type of dose. And this effect was more pronounced in older patients. So people who were middle-aged and older needed frequently doses of 10 times concentrated PRP, 15 times concentrated PRP, 20 times concentrated PRP to get the best response, but the machines don't go that far. So all the rest of this needs to be done in a lab rather than a little bedside machine. Now, that doesn't say anything about mesenchymal stem cells or bone marrow. It just shows us how ligaments and tendons respond to PRP. And then on the bone marrow concentrate side, we published these 3 studies, and then there's a 4th one coming out pretty soon here, where we looked at an easy-to-see ligament, the ACL in the knee, anterior cruciate ligament, and we were able to inject bone marrow concentrate into that, which then caused the effect of healing, meaning that we saw obviously functional improvement, we saw the laxity in the ligament go down, and then we saw improvement on MRI. And we've used PRP for this application as well. So in our extensive clinical experience in both, in treating ligaments, PRP works well for small partial tears in ligaments or lax ligaments. So if the job is smaller, meaning let's say someone just has a stretched ligament that's not severely injured, then PRP will work fine. Bone marrow concentrate tends to work better in larger injuries for ligaments and tendons. So for example, if you've got a ligament that is pretty damaged, allowing a lot of motion, then bone marrow concentrate is going to work much, much better. And all things being equal, if we really don't know which category the ligament tear is in, then bone marrow concentrate will generally outperform PRP. So that's really what this comes down to. It comes down to, at this point, no one's ever done a head-to-head clinical trial comparing these two, but we have done a lot of research on both. And then obviously we've got a lot of clinical experience on both. And that's what we see. So that's kind of why you hear what you hear from us. So I think that's the last slide I had. So let me stop the sharing, and then we'll go to some questions here. Again, this is basically, you can ask questions about this or anything else. It doesn't have to be about this. Diana Clara, hi there. I'm unable to attend today's session live. I'd like to submit following questions. However, can you go over some of the factors you are seeing that make PICL patients better candidates? Yeah, Diana, we have some of that research ongoing, but I can tell you what I think based on what I observe. So what I think I see based on what I observe is that if we have a PICL patient who has an acute traumatic injury, like I was in a car accident 6 months ago, I've had this problem for 6 months, and we're dealing with something like excessive C1, C2 overhang, those patients have high rates of success and generally don't need as many procedures. If we're dealing with things like EDS that's been going on for 10 years, those patients tend to do pretty well, but they need more treatments than the other kind of patient. And in general, if someone's had this for a very long time and 20 years later, they're just discovering this is what this is, and as a result, they're what I call a fragile egg, meaning that, you know, anything sets them off for a long period of time, whether it's this or injecting a trigger point in their muscle, then those patients are much harder to treat. Marie, if a patient recovered well from 5X PRP treatments, the nuchal ligament after whiplash, and re-injured those same ligaments, would they still recover again with more treatment? You know, Marie, I'd really have to know more about what it is we're talking about, what kind of ligament injury we're talking about. But assuming it's just another similar ligament injury, it should recover with more treatment. Now, realize that 5X is probably underdosing. I don't know how old you are. So a 5X PRP would be a good dose for someone in their early 30s to late 20s. It would be an overdose for someone who's 18 years of age. And it would be way underdosed for someone in their mid 40s, way underdosed for someone in their mid 50s, and obviously way underdosed for someone who's much older than that. So we got to really put your age into that equation, because it makes a big difference based on our published research. Now, most doctors don't know that because A, they haven't done the research like we've done it, and B, they get what they get that comes out of the little simple machine that they use. So they don't really look at dosing, because dosing isn't really something that's in the equation for them, because they only get one dose anyway. Oleg, Dr. Rosen is 1.5 hours drive for me. I was thinking to go see him. Does he do DMX as well? And is it in the way you prefer? Do you have a preferred place to get one? Also, is there a way you could write a script and I get DMX done here in New Jersey covered by insurance? I don't think that insurance covers DMX. So unless you got some sort of special policy, I don't think that's going to happen. But we're happy to write you a script. Now realize that legally we can't write you a script until after we've done a telemedicine. And the good news, if there is any good news about the pandemic, right, is that the pandemic extended physician licenses to all 50 states. And they did that primarily to allow doctors to go from one place to another and solve the healthcare provider shortage that was happening during COVID. What that does for us is that means that currently I hold a New Jersey license or a New York license or a Texas license, meaning my Colorado license extends to all 50 states, which is not usual. So I can certainly get on a telemedicine with you, and then once we have a physician relationship, I can write a script. in any state. So that's certainly something that can happen. Then as far as Dr. Rosen goes, listen, Scott does amazing work. One of the world's experts on craniocervical instability, decreased CSF flow in the upper cervical spine, intracranial hypertension. Scott's a world expert on that stuff and probably does the world's best MRIs for that particular set of issues. He also has a DMX, but I would call ahead, obviously, to make sure that the DMX is working, etc. I know for a while there, I think he had lost his DMX tech, so I don't know if he's back to doing it. So that's something else to consider there. Munit, how much or how active should I be during the honeymoon phase? Munit, I think just go back to your normal activities. I probably wouldn't be working out or anything like that, but everything else should be back to your normal activities, because what you're doing during that time is you're also telling the body how strong that ligament should be. Now, you certainly don't want to push it too far, because you can push it too far. So just let your body be the guide, meaning that if you do something and symptoms go up, then do less of it. But if you're doing your daily activities other than a hard workout, it shouldn't be an issue during that honeymoon phase. Regenexx, been advanced by Deanna. Who typically is getting worse and how often is this occurring? I know the data is preliminary, but a reminder of what you're seeing would be very helpful. Yeah, Deanna, I think we need to define that. I think we've done that a couple times on this show, but I'll do it again here today. So the first answer to that question would be, what is it that we're talking about? So usually what it is that we're talking about there would be a flare-up in symptoms that goes beyond the normal. So what's the normal for this kind of procedure? And I think we're talking about PICL here, because that's what the last question you asked was about. The normal is 3 days to 3 weeks for something like a PICL procedure. When it goes beyond that, we're in a prolonged flare-up. And how often is that prolonged flare-up happening? Approximately 1 in 4 to 1 in 5 patients are having a prolonged flare-up beyond that. Then we're into the weeks to months category, and we're in the weeks to months category. The vast majority of those patients who are prolonged flare-up are obviously coming out of that prolonged flare-up. And then when it comes to flare-ups longer than 3 or 4 months, that's a pretty small number out of the total, probably 1 to 2 in 100, something like that. So a pretty small number of patients are in that category. And that's why I have that conversation on a consistent basis about what I call fragile egg patient. That's not derogatory. It just means that that patient's central nervous system can only handle a little bit at a time because of either how long they've been injured, how severely they're injured, genetics, you name it, it's all part of the picture. Metabolic syndrome is another factor there. Patients that are heavier, high blood pressure, etc., blood sugar control, have a much harder time controlling inflammation, those sorts of things. It's been advanced by Deanna. How often are upper facet joint injections in C0, C2 worsening symptoms in patients? I don't think I've seen those injections worsen symptoms in patients on a long term. I think it's the same discussion we just had on any of the injections in the neck. So same exact discussion we had on 3 days to 3 weeks, longer than 3 weeks to 3 months, 3 to 4 months plus, same thing that we just discussed. Regenexx, been advanced by Deanna. How often? Oh, I got that one already. It's been advanced by Deanna. What treatment is best for the bobblehead, and can this be helped with OA? Or is it a ligamentous issue mainly? Or maybe caused by OA? So generally, that's either a ligament or muscle issue or both, meaning that the ligaments that hold the head on are loose, or the muscles that hold the head on aren't strong. Munit wanted to know if you are familiar with V-cell, stem cell IV therapy, and wanted to get your opinion as an adjuvant therapy. Yeah, I think we have to be pretty careful with V cells. So that, as you put there, means very small embryonic-like cells. That was involved with a company that was doing some V cell work many, many years ago. They back then were called Neostem. They ended up getting bought by a company called PCT, which I think has now been bought by another company. But bottom line is, because of that, I got very involved in all of this. Now realize that the researchers out there that are very experienced in this area have done some research on V cells, and there's controversy as to whether or not they exist. The hardcore stem cell researchers say no. There's a group of researchers around Radicek, I think at the University of Kentucky, who says yes. And then as far as our ability to isolate V cells and use them for treatment, we're really not there yet. So I don't think that IV, if someone's claiming to give you an IV V cell treatment, it's going to do much of anything. Realize that there's a pulmonary first pass effect for IV treatments. So if I give you mesenchymal stem cells IV, 97% will end up in the lungs. And in this case, we're talking about how cells are going to get into poorly vascularized ligaments. And that's even less likely to happen. So I don't think it's probably going to make much of a difference. Marie, if concentration on PRP is low, could that just mean that a patient would need more treatments to get the best results? No, it generally means that the clinic you're going to doesn't know which way is up when it comes to PRP, meaning at the end of the day, and I don't know how old you are, but I'm assuming you're middle-aged or older, but you could be younger. So let me know if you're younger. So if we're talking about middle-aged or older here, for a ligament treatment, minimum would be 7x, more likely 10x, meaning 10 times concentrated. And then depending on the patient, size of the problem, we might even use 14x. Like yesterday, I used 14x PRP in a patient that's not that old, early 40s, but we were really trying to go after some things that we had treated more than once, and we're trying to make that the last treatment. But there's a direct dose response relationship in older patients. So the higher the PRP, the better those cells are going to work to repair. So that's the problem. So it wouldn't just be more treatments. It's just using the correct dose on the correct patient. Regenexx, submitted advanced by Deanna. Another question, why does C1C2 overhang from alar laxity worsen over time? Does the overhang correspond to the grade of the tear? I haven't really seen C1, C2 overhang in most patients increase over time without treatment. Obviously, with treatment, our goal is to get it to decrease over time. And generally, yes, the overhang or the degree of overhang responds to the laxity of the ligament or the grade of the tear or both. How close before, soon after a posterior PRP or PICL is okay to get a COVID booster? Yeah, Carrie, this is an important question that I've answered a bunch of different times for patients, so it's good to get this one out there. Really what we're looking at there is trying to make sure that it's either well before or well after this kind of procedure. So what I mean by that is that, at least 2 weeks before, or at least 2 to 3 weeks after, because the COVID boosters cause a fairly stout inflammatory effect in the body. So you don't want to kind of be right in the middle of that inflammatory effect, kind of layered on top of your inflammatory effect from what it is you got injected. So I just put some time before or after. My whiplash accident was 10 years ago. I just started having symptoms about 2 years ago. Yeah, so that's usually not an issue. I'm really talking about people that have been symptomatic for a very, very long time and have very low functional levels because of that. So for instance, talking to a patient who has had this for 20 years, and it's been getting more and more disabling as time goes on. They can't get out of bed, they can't travel, they can't sit upright, those sorts of things. Munich, I wanted to know if you're familiar with, yeah, got that one already. Marie, by 5x PRP. Oh, okay. So getting PRP done 5 times. So just so that you know, when you write 5x PRP from a doctor's standpoint, that means 5 times concentrated. So having it done 5 times is too much. Again, if the PRP is being appropriately dosed and appropriately made, we shouldn't have to inject it 5 times. Now, there are certainly some patients I've treated where we've done that, but more often, if the PRP didn't get them where they needed to go within the first 1 to 2 times, we're switching to bone marrow concentrate, which generally does. So there are patients that might need it 5 times, but that would be more rare. Michelle, I know that after PRP or BMC, treatment for pain includes topical heat, but is there a time frame when Colpax can safely be used for pain? Michelle, it doesn't have to be using hot or cold. And what I mean by that is that it's really left to patient tolerance. So for the deep structures we're talking about, you can apply all the heat or cold over here you want, and it's never going to get to that structure. In fact, heat or cold on the skin doesn't get further than about that deep. So it's usually whichever makes the patient feel more comfortable. Now, we can use a deeper penetrating type of heat, something like infrared. And for infrared, we'll generally recommend that right after a procedure to improve blood flow. But again, there's no hard or fast rule there because sometimes infrared will stoke things up too much. So if you're talking about a procedure at our clinic, try the infrared. If for some reason you're having a hard time recovering and getting too much swelling, then you can back off the infrared and you're fine to use cold. Oleg, sorry, doctor, thinks perhaps you missed one part of the DMX question. Do you have a preferred place? Yeah, so Oleg, we have a number of places around the country we've seen that do good DMXs. And we'll generally send people to those clinics on the list. If you don't have one of those clinics close to you, then we'll generally recommend that you get that done when you come out here. So we'll try hard to make sure we can get it done locally because that's always more convenient for everybody. But if for some reason you can't get that done locally because there isn't a good place that's on our list, meaning we've seen the quality of their work and we approve of that, then we'll have you come in here. Anya, I actually have chronic tonsillitis and tonsil stones, and I need to have a tonsillectomy before having a PICL. I have a left TMJ dislocation, so having tonsillectomy would be hard because the mouth needs to be open wide, but I'll do it if needed. I wanted to consultation with you to figure out if it makes sense for me to travel to the U.S. for treatment. Unfortunately, I can't wait until November. I have to have a consultation with Dr. Schultz. He has availability. And then I think it cut off there. So Anya, we have done PICLs in patients with tonsillar stones. Usually the tonsils don't get in the way, but we'd probably want you to take a picture of them so we can confirm that they're not going to get in the way. That would be the only concern. Oleg, can CCI cause a feeling of like an almost muscle soreness in the arms, especially triceps? Yeah, Oleg, that could be CCI. That could be problems at C7, the C7 nerve. So I would need to look at your MRI to venture an educated guess about which part of the spine that would be, but could be either. Francis, how often do you personally miss the joint your first try with the contrast? Yeah, Francis, that's a good point. So it depends on what the joint is. Obviously, we're talking, I don't know, 60, 70 different joints in the body, no more than that, include all the facets, probably 80, 90 different joints in the body that can be injected. But let's start maybe with cervical facets because that'll hone in what it is we're talking about. So if we're talking about the lower cervical facets, how often in experienced hands under proper x-ray guidance do you get into where you want to be? That's then confirmed as intra-articular by the contrast. I would say if someone spent their entire career doing that kind of work, meaning they're using contrast confirmation on a regular basis, and they've done that for decades, we're talking about a miss rate of still about 1 in 3 not being in the joint and having to adjust the needle to make sure you're getting the correct flow in the joint. Now, that's very different than if you've never done a contrast injection, meaning those folks that are just using an X-ray machine and putting the needle somewhere in the vicinity of the joint. That's going to be 1 in 100 chance of getting in the joint, or 1 in 20, or something like that. So not real high. Francis, are the joints of the hands and feet difficult to inject? What about the interlocking joints of the carpals and tarsals? Do you have to hit each specific joint, or they communicate such that the fluid flows around? Yeah, so hands and feet, depends on which joints we're talking about. The ones at the very end are pretty tough to inject here, even under ultrasound, because they're obviously extremely small and don't have a big space. This one and this one, the PIP and MCP, much easier to inject. CMC, much easier to inject. Those usually inject under ultrasound. When it comes to foot, tibia talar joints, pretty easy to inject. And then usually those are all separate joints. The only ones that flow around each other would be the joints in the wrist. So the wrist joints do flow around. So if you were to inject one portion of the wrist intra-articular, you can see it go throughout the different parts of the wrist intra-articular. Oleg, during my worst neck symptom moments and positions, I also get subtle squeaking, creaking on the right side of my mid-lower neck. What could that be? 2018 supine cervical MRI mentions mild dextroscoliosis, a mild facet hypertrophy, small disc bulges. Yeah, so like we were just talking about that triceps weakness. So the facet hypertrophy and the dextroscoliosis could be putting some pressure on that exiting nerve or irritating it. And you're probably hearing degenerative instability with the creaking. GB man, I had one PRP treatment of bone fracture. There has been little to no long-term improvement. Would recommend to try treatment again, or would traditional ortho be the way to go next? GB, I'd have to know so much more about what kind of fracture we're talking about, how long you've had the fracture, who injected it with PRP, how did they inject it with PRP? Was it done with X-ray guidance, ultrasound guidance, blind? What kind of PRP they used, high dose, low dose, leukocyte rich, leukocyte poor. So lots of unanswered questions there for me to be able to comment on that. Can I ask if the clinic that takes 50 ml blood and gains 6-7 millimeter PRP, what does it sound like a good quality PRP? Not so much, no. Anya, what you can do there is you can roughly figure out the concentration. You're not going to get exact because it'll depend on the efficiency of the isolation. But when you make PRP from 50 mLs of blood, you start out with 50 mLs, and half of that's going to get thrown in the trash. So you're really starting out with 25 mLs. And then from that 25 mLs, going down to 6 to 7. So if you just do some math there, so that's around a 4x PRP, somewhere in there, give or take. So that's pretty bad. Meaning that in order to make, so if we wanted to make 1 cc out of 50 mLs of blood of a highly concentrated PRP, then we'd be at approximately a 25x. If we did 2 cc's, let's say 12x. So if we're trying to get to 10x, that's what we were talking about. That's a common thing in middle-aged tendons. That 10x PRP, we might get 3 or 4 cc's of 10x PRP out of 50 mLs of blood. So no, that's pretty bad PRP, just looking at all of that. Joe Henry, curious to know if a heavy head feeling plus frontal head pressure at times after PICL is pretty normal healing and will diminish after the inflammatory response. Yep, pretty normal after that kind of treatment for sure. What laxity does a C2 axial sponge rotation over 30 indicate? Yeah, so axial rotation or rotation of C2 would normally be, could be alar ligaments, could be problems with scoliosis, could be, in addition to that, pulling by the thoracodorsal fascia on that side, Obviously, it could be shortening in some of the muscles that connect to C2, and there's quite a few, all of those good things. Apple, I don't want knee replacement, which is better, PRP or bone marrow. You know, if you're a knee replacement candidate, normally bone marrow concentrate outproduces or has better outcomes than PRP. Unit, do you prefer PRP versus BMC for SIJ, and would you inject in the joint or lumbar spine if it's bilateral? You know, a lot depends on how severe the SI joint problem is. If the SI joint problem is fairly minimal and minor, or to moderate, then we use lots of PRP. That would be in the ligament and sometimes intra-articular. If we're talking about a much more severe SI joint instability, then bone marrow is what would be used. Oleg, could these all be caused by CCI2, or is it likely something else? Besides my neck, head, upper body symptoms easily linkable to CCI, I've been having lower body neuro symptoms, specifically regular fasciculations all over, pelvic floor dysfunction, dribbling urine, constipation, trapped ejaculation, sudden strong urinary urges of liquids, sometimes feeling as I have soreness, about to cramp in calves, pressure in the right toe. Yeah, Oleg, it's possible, but obviously we're talking about many, many things that overlap all of those. So obviously you'd want to have been checked out by neurology to make sure that we're not dealing with MS or ALS or those sorts of things. Have had a clean brain MRI to make sure we're not dealing with MS. And seen by urology to get the issue with an ejaculation looked at, etc. But certainly some of those symptoms we see in CCI patients, but obviously we want to make sure that all the other stuff is checked out. Is there a connection between CCI and sleep apnea? Yeah, Jeanette, big connection as far as we see. So I think I did a blog on that one, or I think I just did no, I think we just did a YouTube video. Nah, maybe. I don't know. I'm gonna search the blog first, make sure, see what's there. And if I find this, I'll share it with you here. Yeah, here it is. Okay, yeah, I even drew some really cool pictures for all of this. So let's see here. Let me go ahead and share. Okay, so this is the blog. If you just go to the regenexx.com site and go to the blog and then type in just apnea, A-P-N-E-A, which would be the US American spelling, then you'll see that article. But basically, whoops, I guess I'm only gonna stay on there as long as I'm on it. So basically, it goes through how it links to CCI, goes through the normal cervical spine anatomy, how C1 instability might impact the airway, how C2 instability might impact the airway, how decreased cervical lordosis might impact the airway, etc. So good article to read about all of that. My jaw displaced about 3 weeks ago after getting cervical PRP at CSC, not because of PR. I've had multiple displacements in TMD since I was young. Jolly Ranchers caused it this time. Gotcha. Will this displacement affect my cervical healing or beginning a TMJ splenopyment? So, Peter, it sounds like now maybe you can put down in there, did you also get your TMJ ligaments injected? Because that would be a key thing to add there, meaning if you have this chronic TMJ problem, it's certainly not helping the neck and vice versa. So if you haven't gotten the TMJ ligaments injected, that's definitely something I'd recommend the next time. As far as getting a splint goes, I think I'd go the direction of getting the ligaments tightened rather than a splint. Oleg, you said subtle creaking during flare-ups and movement of the neck is one part of degenerative instability. If I heard correctly, could you elaborate, explain? Please. Yeah, degenerative instability. Let's see if I've got a good blog on that one. I know I've talked about it a lot, but we'll see here. You know it's bad when you have so many blogs you can't remember them all. Yeah, so this is basically a very similar concept here. So this would be a good one to look at for degenerative instability. So basically the idea, this is more spondylolisthesis, but it's the same concept. This is just more severe type. And what degenerative instability means is that the ligaments that hold things together are loose and the muscles are atrophied. So the spinal segment just moves around too much. And that causes that crepitus or creaking. But this is a good one. Obviously, I'm recording this video so you can go back and get the URL or go to the regenexx blog and type this in, either one. Daniel, my instability is only on one side. You can inject just the other ligaments on one side with picl. Sure, that can be done for sure. Francis, in Monday's podcast, that you said that shipping pre-thawed stem cells overnight is not a viable process. How do you reconcile that with autologous countersite implantation, other stem cell drugs where the cells are handled that way? There really aren't stem cell drugs on the market, so those don't exist right now. But when it comes to shipping cells overnight, like autologous chondrocytes, a little bit different gig, right? We're talking about chondrocytes, which produce a matrix. So they're going to be able to withstand temperature changes better, but you're still going to lose a large number of chondrocytes. So at the end of the day, you know, you'll send, let's say, I don't know, let's make this up, 1 million cells with 96% viability. And by the time they get there, depending on how carefully you get them there and how quickly they're warmed, you're probably going to be down to 50% of those cells dying, something like that. So still the same problem. Again, it can be done. It's just not a good way to do it. So, and as we talked about, when it comes to mesenchymal stem cells that are even more temperature sensitive, we use a 2-hour timer on those cells, and they can't go above that 2-hour timer or we start freaking out. So that gives you some idea of what that viability looks like over time once they're out of culture. Anya, and guys, just to let you know, regrettably, I'll have to end in about 6 minutes just because I have a meeting after this that I got to get ready for a little bit. So we'll be cutting it a little bit short today, but great questions. Thank you so much for your experience. If a patient is dependent on cracking their neck to alleviate pain in the neck and during swallowing and to get more freedom of motion, can picl plus posteriors help significantly? Also have to crack thoracic spine, and that's the only thing that helps the pain and stiffness. I have to lay down most of the time because movement worsens pain. Is possible to get something better with regen or only fusion? Yeah, Anya, you know, listen, there's a lot to unpack here, and I think the only way I could really tell you that would be through a telemedicine visit, where I look at all the information, go through your extensive history, etc., and then from there I can probably make some predictions. But with just this kind of information, that really isn't possible to do. I also want to ask if first PICL posterior injections don't work or don't help much, can this person still get a second round? Yeah, so Anya, we do allow that now. For a while, we weren't allowing that when the procedure was newer, but we do allow that to happen now, and obviously work with the patient to see what's the best fit. Oleg, following up on lower body symptoms, relation to CCI, had clean EEG, brain MRI, neurologist Dr. Roy, local doc, maybe an EMG there, and a big neurodegenerative disease. Most of us. Okay, well, good. So that's helpful. That's really, really helpful to hear about, because that obviously tells us that we can start crossing some of those really bad things off the list and then get into, yeah, that's the kind of stuff that does happen in CCI. Jackie, massive love and gratitude for you and your staff. Thank you, Jackie, so much. You know, we have a very hardworking staff at Centeno-Schultz. they don't get enough credit, but I constantly hear great things about them. So thank you so much. Marie, can you overtreat a ligament even if things keep getting better and pain keeps decreasing? Generally not. So not a big concern. Oleg, what could be explanation for CCI HDS patient to have muscle tension all over body since symptoms started many years ago? Urge to need deep massage and adjust most parts of the body. Yeah, so the biggest concern there, or the biggest thing, is that instability equals spasm, right? Something moves too much, the body's reaction is to tighten down the muscles. So for an HDS patient, they're unstable all over the place. So they're going to have more spasm, especially as they get older, and things start to break down than the average person, meaning that instead of using their ligaments to stabilize those joints, the body is trying to use the muscles, and the only strategy available to it to use those muscles is spasm. Okay, guys. So that is my last question here. I am going, oh, one more came in. I'm going to go ahead and answer this one, and then I'm going to wrap it up just because I've got to get to a meeting. Francis, the fledgling international market for viable allogeneics, stem cells, a patient go to Mexico and get ultrasound-guided knee injection, 50 million MSCs for $3,000, which is less than a BMAC procedure cost in the US. Why should patients choose a US procedure over this? Yeah, I'm not sure. That's an easy one to answer, primarily because number one is if I went to Mexico to get 50 million MSCs, I would have no earthly clue whether or not I got 50 million MSCs, meaning that even as an expert, I'd still be blind. This reminds me a lot of some of the talks we had 10 years ago about China, meaning there was lots and lots of clinics opening up in China. And at the time, we were actually talking to some of those clinics through another company I was working for. And we were trying to figure out whether or not the tissues that we were getting had actually been tested as they were supposed to be for communicable diseases. And the answer was, we had no idea. In addition, we were trying to make sure that they were sourced appropriately, i.e. that they weren't killing babies to get these things. And again, we had no way to determine that. So as far as what you get for $3,000 in Mexico, I wouldn't have a clue. In addition, the biggest problem in Mexico, I think I've talked about, or in Panama, or in any of those places, is you're using a local yokel doctor. So the kind of stuff we talk about all the time here, this interventional orthobiologics, which requires x-ray guidance, ultrasound, and years of training, you're not going to get in Mexico. None of those guys have any of that training. So if they do use ultrasound to get into a knee, you're going to get a simple intra-articular injection rather than injecting the 30 structures that you can inject in a knee if they need it. But ultimately, my biggest fear wouldn't even be that. My biggest fear was, how do I know I'm getting 50 million MSCs? There'd be no way to know, and a high likelihood of some serious fraud going on there. So that's probably my best answer to that. Meaning, would I send a family member down to Mexico to get mesenchymal stem cells? I wouldn't, primarily for that reason, right? I would have no idea what it is they're getting, even as an expert. Now, I could probably figure it out if I asked enough questions and pushed on enough parts and pieces of the system. I could probably get to that moment where you're like, that doesn't sound right. But that's only, after doing this for 20 years and being involved in cell culture for 20 years. Let's see. Anya, I understand. Thank you. Is there any way I have to country with this month of September? Yeah, Anya, reach out to Carla. We do have cancellation slots. So that's something, you really want to reach out to her on, because we do have people obviously that develop COVID or whatever, and people cancel. So definitely reach out to her. Incredible doing these live streams and giving us hope. So grateful any chance that colleagues will start doing them. Dr. Schultz. That's a question you'll have to ask Dr. Schultz. Obviously, the big commitment to do these. So that would be a good question directly for Dr. Schultz or some of the other doctors. That would be great as well. Okay, guys, so I'm going to wrap it up for today. Thank you so much for spending your time here today. I think I'll be doing this on Monday. I won't be doing it this coming Friday. Oh, wait, no, yes, I will. Monday and Friday should be good. Just thinking about that. On this weekend, we got to take my youngest son to college, but that we don't leave till Saturday. So I think we'll be doing this on a Friday. So anyway, have a wonderful weekend and great questions today, and stay safe. Thank you.